Value-Based Incentive Payment System, or MIPS, is one of two participation paths of the new Quality Payment Program, or QPP. The Quality Payment Program contained within MACRA, the Medicare Access and CHIP Reauthorization Act of 2015, is part of a broader effort by CMS, the Centers for Medicare and Medicaid Services, to shift from a volume-based payment system to one which rewards clinicians demonstrating high quality and value by penalizing those who are not. The QPP replaces and consolidates several legacy Medicare programs, combining them into a single program with flexibility that allows participants to choose the activities and measures which are most meaningful. MIPS consolidates the Physician Quality Reporting System, or PQRS, now the Quality Performance category of MIPS, the Value Modifier Program, now the Cost Performance category, the Medicare EHR Incentive Program, now the Advancing Care Information Performance category, and adds a new fourth performance category called Improvement Activities. Now I'd like to introduce Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst.
The performance of MIPS participants, referred to as eligible clinicians or ECs, is measured across the four weighted performance categories on a 100-point scale called the final score, which is then compared against an annual performance threshold with Medicare Part B reimbursement rates adjusted based on program performance. In 2019, the quality performance category is worth 45% of the final score, cost is worth 15% of the final score, the improvement activities performance category is worth 15% of the final score, and the promoting interoperability performance category is worth 25% of the MIPS final score. The promoting interoperability, or PI, MIPS performance category, worth 25% of the MIPS final score in 2019, replaces the legacy Medicare Meaningful Use program and focuses on key measures of health IT interoperability, promoting patient engagement and electronic information exchange. It uses several of the same measures clinicians have been working on for years under the legacy Meaningful Use program, but this performance category has undergone a significant overhaul for the 2019 program year, including a name change from Advancing Care Information to Promoting Interoperability. For the 2019 program year, participants are required to use EHR technology certified to the 2015 standards and must report on the corresponding PI measures for a minimum of 90 continuous days in the calendar year. Thus, in 2019, MIPS participants must ensure that they are utilizing 2015 certified EHR technology, referred to as CERT, no later than October 3rd, 2019, which still leaves participants exactly 90 days in the calendar year for their 2019 PI reporting period. Along with losing the option of utilizing older versions of EHR technology in 2019, participants also no longer have a choice on what PI measure set to report on, and this year's scoring methodology has undergone a significant change, eliminating the base, performance, and bonus scoring of previous years in favor of a more streamlined methodology which focuses exclusively on clinician performance on the PI measures. For 2019, CMS aligned the PI performance category requirements with the recent changes made through the 2018 Inpatient Prospective Payment System, or IPPS, final rule, which overhauled the legacy Meaningful Use requirements, reducing the number of objectives and measures to significantly reduce the reporting burden on participants. The four remaining objectives are e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. Then, within these four objectives are the corresponding measures. Within e-prescribing, we have electronic prescribing of permissible prescriptions, query of prescription drug monitoring, which is optional in 2019 and earns possible bonus points, and verify opioid treatment agreement, which is also optional in 2019 and earns bonus points. Within the health information exchange objective, we have support electronic referral loops by sending health information, and support electronic referral loops by receiving and incorporating health information. The provider-to-patient exchange objective only contains one measure: provide patients electronic access to their health information. And finally, the public health and clinical data exchange gives participants 5 measures to choose from, with clinicians attesting to being in active engagement with any 2 of them, which could be 2 different registries from the same measure: immunization registry reporting, electronic case reporting, public health registry reporting, clinical data registry reporting, or syndromic surveillance reporting. Also, please note that the Protect Patient Health Information objective, which contains the security risk analysis measure, is still an annual requirement within the MIPS PI performance category, but it is no longer scored as its own measure, and it is not included in the category's composite score. Thus, participants must still complete an annual security risk analysis, as they have done in previous years, but its completion does not contribute to the PI performance score. In this newly revamped scoring methodology, which now focuses exclusively on individual measure-level performance, each measure is scored based on the MIPS-eligible clinician's performance for that measure, which is based on the submission of a numerator or denominator, or a yes or no submission where applicable. The percentage-based measures, meaning those that generate numerators and denominators, must each be reported with at least 1 in the numerator, unless a measure exclusion is claimed. The scores for each of the individual measures are then added together to calculate the category composite score of up to 110 possible points, with 100 points earning full category credit. If measure exclusions are claimed, the points for those measures are reallocated to other PI measures, allowing ECs the flexibility to focus on the measures which are most relevant to their scope of practice and technological capabilities, without missing out on valuable performance category points. This year's revamped scoring methodology is easier to understand. However, the reduction in overall points available, from 165 in 2018 to only 110 in 2019, means it will be much more difficult to achieve a maximum category score of 25 points in 2019 and future years of the program. In the first 2 years of the program, those who had previously achieved meaningful use often received full category credit. But with this year's scoring methodology and measure changes, that may no longer be the case without additional clinician focus and effort. With some built-in program flexibilities, a clinician's PI category score may be reweighted to 0%, meaning they do not have to submit PI performance category data, and shifts that weight to the quality performance category, making that category worth 70% of the MIPS final score instead. The following provider types qualify for automatic PI performance category reweighting to 0% in 2019. Hospital-based clinicians, clinicians who lack face-to-face interactions with patients, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, physical therapists, occupational therapists, speech-language pathologists, audiologists, clinical psychologists, registered dietitians, and nutrition professionals. These ECs can optionally choose to override this automatic reweighting and report PI category data anyway. And if reported, CMS will override that automatic reweighting and score their PI performance accordingly. With some of these PI-exempt provider types, especially those who have previously participated in the legacy meaningful use programs, such as nurse practitioners, it may be more advantageous to submit PI data for scoring, since these clinicians may find it more difficult to achieve those 25 points under the quality category than under promoting interoperability. Through an application process, a clinician can also apply to have their performance category score reweighted to 0 and have that weight shifted to the quality performance category for reasons such as insufficient internet connectivity, extreme and uncontrollable circumstances, or lack of control over the availability of CERT. In summary, the Promoting Interoperability MIPS Performance category replaces the legacy Medicare Meaningful Use program. The scoring for this category, which is the primary difference from the prior legacy program, has undergone a significant overhaul in 2019 and now focuses on 4 remaining objectives: e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. Participants in this performance category must use 2015 certified EHR technology in 2019, and although it is no longer a measure which earns performance points, participants must still complete an annual security risk analysis in order to meet program requirements. There are flexibilities built into this performance category which allows for category reweighting based on certain conditions or types of providers. And achieving the previous meaningful use requirements often translated into a high PI category score in previous program years. But with this year's significant objective measure and scoring changes, that may no longer be the case without additional effort.